The reason why we choose was this a bit of interactive workshop where we'll see the simulations, we'll see different scenarios, and you can put up your inputs, and that website is the one where whatever you enter there will be displayed right away there on the screen. What is the choice you made, and then we can have a discussion based on that. Okay, we're all ready to start? Sure, please start. Before I start, I would like to thank the Macway team for providing us with this wonderful MacFin, Maniquet, and the entire simulation equipment for that.
So just to orient yourself, what you see on the screen, I'll just read it out to you, sir. Give me a minute. Just to orient yourself, what you see on the screen, at the bottom will be your patient parameters. To the left of the patient parameters, what you see there will be your ECMO parameters, flow, RPM, and the pressures. And on top, you have the FiO2 sweep and ACT. Any relevant X-ray, echo, or other parameters that you want to be shown will be shown at the center of the screen. Just put up the case. I'll just so the number is 7616-9429. So the menti.com number code that you have to enter is 7616-9429.
We'll start with the first case. Sure. So the first one is a young male who presented with an infective kind of picture, fever, chills, myalgia, and headache. Then he had intermittent cough with a shortness of breath, and there was an infective kind of sputum also. Please go ahead. So he presents to the ER. He ignores for some time and he presents to the ER. On presentation to the ER, you see that when they need to connect an oxygen immediately because he was desaturating, and in spite of connecting the oxygen, keeping up to 4 liters per minute, you find the saturation just barely goes up to 97%. On room air, it was close to 83%. So he was immediately shifted to the ICU. His respiratory distress worsens in the meantime. He has to be intubated. Then since the saturation doesn't settle, then you go with the next step, that is sedate, then paralyze. Then you go for recruitment maneuvers, put up the PEEP, then you prone the patient, you start nitric oxide also, and at one point you are on the maximum what you can do from the ventilator, 100% oxygen with a good PEEP, with a good inspiratory pressures. In spite of that, you're not able to handle the situation. This, to put it in a nutshell, the patient is progressing or is already in an ARDS kind of picture. And the X-ray comes out to be something like this. This is how the monitor of this patient shows in the ICU. You see that the vitals, though reasonably stable, with saturation being on very low side, you are from the ventilator, and you see that the EtCO2 also being a bit on higher side in this patient. Next. So what next? Obviously, nothing worked out from ventilator. You have to think of ECMO as an option. So if we have to go for ECMO, what will be your preference? Display that didn't came, Menti didn't. Right, okay. So indications. Right, okay. So now we'll show the slide that Menti or what is in the. Okay, so what we need, yes. So as most of you have said, that needs a Vva Ecmo. Okay, but what we need to do before that, as discussed in the previous thing, check an echo and see that heart is good. Okay, so let us briefly look at what are the indications for Vva Ecmo. I suggest all of you go through the guidelines from the ELSO, where it clearly states you categorize the patients into 2 categories. One is where ECMO is probably required and where you definitely have to do it based upon the mortality. And that is calculated based upon 3 different scores, the Murray score and AOA score. So that in every patient you have to look at that parameters, calculate the score, look at when it is possibly indicated, and then when you have to definitely do it. Based upon that, you take a call about when to institute the Vva Ecmo. Go ahead, Sindhu. So if you are planning a cannulation in this patient, you have decided to go ahead Vva Ecmo. So what will be your choices for this? Again, you can go on your browser. Okay. As most of you have shown, that's the preferred way, femoral plus jugular. But again, femoral is not a contraindication. It's just an individual preference and institutional choice. Okay, next one. So cannula size, this also we discussed in detail in the previous cannulation workshop. How you're going to see the cannula size, see the vessel size, into 3 is the maximum you can do. You discuss with your perfusionist, whatever required. If it is smaller than that, you can do. So a little bigger also, probably you can dilate and do it off also. Okay, next we'll go. Next. So this is what we have decided in this patient, to put a return cannula of 21 and a drainage cannula of 25. And once we go on, then you put the patient to the resting lung settings. That is minimal respiratory rate, a minimal FiO2. That is most important in this patient. Next one, Cindy. So what is the reason for this? I'm sure all of you would have attended that morning ventilation talk on that, to prevent all these. These are the reasons for a continuous VILA, ventilation-induced lung injury, to prevent your barotrauma, atelectotrauma, alveolar strain, all these things. You have to bring down your respiratory rate, bring down your tidal volume, peak inspiratory pressure less than 25, and a PEEP that is optimally required. That will be the targets for maintaining in these patients. Okay, this is the next scenario what you face. You put the patient on ECMO. As you see on the left side of the screen, you're having a flows of close to 4 liters per minute. You're on a reasonably good RPM there. Then you see the clinical monitor of the patient. You see that he's still desaturating, though he's having a stable vitals. So his saturation is only 72% in spite of flowing 4 liters from the ECMO. So what all you do in this kind of situation?
So we have put the patient on ECMO, and we initially had a good saturation, and slowly his saturation has reduced. So what do you think is the main issue, and how are we going to go about it? Are we putting the... We'll go ahead. Okay. So most of the answers are already there. So to go about it, if you have to manage practically in a Vva Ecmo in the bedside, how do you manage hypoxia? Yes, recirculation is the first thing we all of us think if the patient is on Vva Ecmo. But what I would suggest is, if the patient is hypoxic, first see from the patient end till the patient end. So first see the cannulas, whether the cannulas are okay. Then see whether the connection is okay. See whether there is any kinking in the circuit. So see whether the oxygenator is functioning well, whether there is any clots in the oxygenator, visible clots in the oxygenator. Then come next, then you see the post-oxygenator part, then see the color difference, then do an imaging of the patient, and that is how it is a stepwise approach, so that we don't miss the common things. And then finally recirculation, yes, definitely we need to tackle, but before these are the practical things. One of the situations we encountered, suddenly there was a flow fluctuation, we had from 4 liters dropping to 1 liter. We checked everything, we checked recirculation, we checked cannula position, we checked clots, and we were troubleshooting for 2 hours. Then finally what happened is just they tried to push the ECMO machine, and the venous cannula behind the ECMO machine had kinked. So just altering that solved all the problem. We gave 1 liter fluid bolus, so many troubleshootings we did. So what's the point I'm trying to say is, just check every part of the ECMO circuit till it reaches the patient and coming from the patient. I think that gives you the clue. Finally, when you are looking at recirculation, yeah. What is it? Yeah. So this is the cannulas. Finally, if you are done the basic troubleshooting, coming to recirculation part, which is very very probable and very practical thing which happens in a day-to-day ECMO situations. What we need to check always is, we need to check the cannula positions. So ideally what is described is a 15 centimeters gap between the two cannulas, the tip of the cannulas. So 15 is described, like I said before. Practically we need to see whether this cannula position is causing recirculation or not. And the one thing to find it out easily is, one thing is X-ray, second most practical thing is a bedside echo. If you see the echo, you see the drainage cannula, if it's migrated into the RA, if you see the IVC, it's very much into the RA, then we can reposition. So that is one thing before we get the X-ray. Sometimes X-ray might be technically difficult. Bedside echo is the very easy solution to all the basic troubleshootings in ECMO. That is one thing. Okay, there is recirculation. How are we going to manage it? How are we going to find it out? Sometimes evident recirculation may not be there in your color difference. Color difference happens only if pre-venous saturation, pre-oxygenator saturation is more than 80%, 85%. Then you see a significant color difference. That is obvious recirculation. Subclinical recirculation, what we need to do is 2-3 things we can do practically. One is, every day morning we have to see a pre-oxygenator gas, pre-oxygenator ABG, and trending pre-oxygenator saturations gives an important clue. Like for example, you are starting with a 60% saturation on day 1 of ECMO. I am telling a pre-oxygenator, not the central venous saturation of the patient. So pre-oxygenator you say 60%. It's increasing, 65, 70, 75, 80. That gives a clue that there is some recirculation setting in. That is one. Another thing is, how do we really calculate what is the recirculation fraction? There is a formula for that. What we need to do, you just need 3 gases. You need a pre-oxygenator gas, you need a post-oxygenator gas, and you need a central venous oxygenator gas. So when you see the difference between the post-oxygenator gas minus the pre-oxygenator gas divided by the central venous PO2 gives the percentage of recirculation. Clinically accepted recirculation is around 20 to 25%. Again, if even with 40% you are able to maintain a good saturation in the patient, there is no hemolysis, leave it. There is no need to alter the cannulas and mess around with the cannula position. So this is if it is going to contribute to hypoxia, this is the troubleshooting. Then you first see whether there is a color change. If you are not able to see the color change, go ahead, do the pre-oxygenator gas, do a post-oxygenator gas, do this calculation. You are convinced that there is a recirculation, go ahead, do the imaging. Under imaging guidance, reposition the cannula. It's easy to reposition a groin cannula than the neck cannula. So first try with the groin reposition. If you are satisfied, leave it. Otherwise, the neck cannula also you can reposition. Measure how much you want to remove, and then you can reposition. Yeah. Next. Yeah. So the next scenario would be, again, you are having the patient is okay on ECMO. Suddenly there is a desaturation and there is flow fluctuations. You are starting with a comfortable 2500 RPM, 2800 RPM. You are able to achieve 4 liters flow, and suddenly you see there is a flow fluctuation. So what do you think is the most common cause here, and how are we going to manage? Sorry? Yeah. What is that phenomenon called? You can show the video? So this is how it is. So what is it? So chattering. So what is the meaning of this? It's just that there is an excess negative pressure. See, ECMO is a positive pressure pump. You are sucking in it at a very negative force. So you need to have a volume in the venous chamber for the ECMO to pump out. And once there is no volume there, this kind of chattering happens, the collapse. That is because the veins get collapsed around the cannula and the cannula starts shaking. So how are we going to manage? What are the basic troubleshootings in a case of chattering? First thing is reduce the RPM. So first thing is reduce the RPM, that immediately tackles, then give volume. Okay, then give volume. Even when you are giving volume, we need to assess. See, it's very easy to give volume in an ECMO circuit because perfusionist is there, it is hanging, it's easy, it solves the problem, you get good saturation. But finally, you are going to deal with positive balance and mismatch between an intake output. You are going to deal with renal overload. All these are practical problems when you are going to just challenge without analyzing what is the reason for hypoxia and chattering in an ECMO. So before we give volume, we need to really know what is the reason for hypovolemia, whether it can be tackled without giving volume, and what else we can do. One of the things would be this much flow is not even necessary for that patient. So we are giving unnecessarily high flows and then cause chattering. It's not necessary. So come down on your flows. See, with that, sometimes when the chattering stops, saturation improves. You don't even have to do anything. So that is one. Second thing is, again, if there is time, do a quick echo. Echo will be your tool, your pal, always in an ECMO. See whether the LV is good, LV is empty. Guide always with all these small information which you are going to get, and then give fluid. Giving fluid is easy. Just reassess whether it is necessary or not. Yeah. Another thing about chattering which I missed is the cannula position. Again, cannula positions also can cause chattering. If the cannula is too much into the RA and it is getting collapsed every time there is a contraction, it can be a possibility. Another thing is if it is too low down and it is not causing good drainage, I mean it is below the hepatic veins, it is not giving you adequate drainage, that also can be one of the reasons for chattering. So see, ideal position what is suggested is the high VC hepatic junction would be an ideal position. It does not block the hepatic veins also, and it causes good drainage also. So that is the ideal position. Even though it is secured very well, there is a chance that the cannula can slip. So every day what is easily followed protocol is when you initiate ECMO, note down the centimeters what it is fixed. There will be you keep an ECMO perfusion chart hanging on the ECMO circuit. It is fixed at 45 centimeters. So every day when a person is coming and doing the dressing, at least that centimeter has to be visible. So if it's not visible, either it is migrated in or it is migrated out, whatever. So it's easy for us because all these patients, especially with COVID, we are going to keep them on ECMO for more than a month. So your initial suture is not going to hold for more than 10 days. However good we secure the sutures. We initially thought putting a purse string was very good, but purse string itself causes skin necrosis and causes further migration. So identifying at what level we place, it's a quick guide based on and with the aid of your imaging. Yeah. Anything else? What is this? Yeah. So next scenario, now we have done all the troubleshooting. Patient is on day 11 of ECMO, and this is the ECMO. You can see in the right upper corner, you can see the ECMO settings. It is FiO2 0 means it's FiO2 room air, and the sweep gas is 0, ACT is 200, saturation is 98, flows are 4 liters. So what is this setup? What do you think is this setup? Is this patient ready for weaning, or is this patient still not ready? How are we going to go about weaning in a Vva Ecmo? This is basically Vva Ecmo. Weaning in a Vva Ecmo. So just to quickly tell how the scenario, I mean the sequence in which we are going to start weaning. First thing will be when we initiate an ECMO, we need to take care of few things. One is the patient is going to be severely hypoxic and is going to be hypercapnic. So when we are going to initiate ECMO, the goal has to be to maintain or to maintain perfusion to the end organs, but we should be very careful and very vigilant in bringing down the CO2 of these patients. So when we initiate ECMO, we should see to it that the CO2 is at least above normal or it is just in the normal. We should never, patient should never be hypocapnic because it can damage the perfusion to the brain. So that is one thing. So once the ECMO is established, we are going to keep it at 100% FiO2. We are going to keep the sweep gas at least equal to the ECMO flow rate or twice the ECMO flow rate. This is how we are going to go about. Then we are going to keep under rest settings. Then each day we are going to reassess the patient's ECMO parameters. We are going to reassess the recovery of the patient. Once in the rest setting, you are seeing that the tidal volume is improving. Say you are keeping a rest setting of 10 in a pressure control ventilation 10 centimeters, you are going to get a 50 ml tidal volume. In the same setting, if the tidal volume is increasing 100 ml, 120 ml without doing anything, that means the lung is recovering. Then we can challenge this patient, increase the ventilator settings and see whether we are going to achieve at least 5 ml per kg tidal volume. If we are able to do that, then he is at least ready for a weaning trial. Then we can slowly start reducing the ECMO flows. How we are going to go about reducing a Vva Ecmo is, we are not going to touch the flow at all. We are not, because it's not going to be a cardiac support. It is only a respiratory support. So all you need to do is, let it be a blind circuit. Finally, it will be a blind circuit. You don't have to reduce the flows in any way. What we can do is reduce FiO2, reduce the sweep gas. Again, if you are going to do both at the same time, it is going to lead to confusion. So practically, it may not be, it's not hard and fast rule. Practically, what is easy to do is, first reduce the FiO2. Reduce the FiO2, bring it to 50%, 40%. Then if your sweep gas is 6 liters, 7 liters, bring it down. Bring it down. If your ECMO flows is 4 liters, bring it down to 2 liters, something half of the sweep, half of your ECMO flows. Then bring down the FiO2 to 21%, drop the sweep gas flow to 0%, then increase the ventilator settings to get good oxygenation like in this patient. Once this is done, 24 hours, run it with 0 sweep gas and room air, and then take a call whether this patient will tolerate removal of ECMO. So that is an ideal way to wean an Vva Ecmo. So yeah, go ahead. This is just about decannulation. We'll just sweep through all this. VA. Any questions? This is about VV. So can we move ahead to VA? You have any questions? You are free to ask. So coming to the, can I go ahead? Patient is a 45-year-old man. He is previously healthy, complaints of 4 days of fever, dry cough, CT scan revealed bilateral patchy infiltrates, ground glass opacities. Presumptive diagnosis was fulminant myocarditis, cardiogenic shock, continuous oxygen, dobutamine, norepinephrine, diuretic, empirical antibiotics on, and other conservative measures. Despite this, he does not improve. So this is the patient's ABG. He is having an acidosis. He is having a base excess of -14, increasing lactates, and borderline oxygenation. So what are we going to do? So this is the patient scenario. His heart rate with ectopics and blood pressure fluctuating, 60s in systolic pressures, saturation is borderline, PCO2 is low, and how are we going to go about? So this is whole or? So anyway, this is straightforward. So this is a scenario where there is a cardiac involvement, there is a hypotension, myocarditis, diagnosed myocarditis. So we have only a choice of Vva Ecmo in this patient. So we will be going ahead with a Vva Ecmo. Go ahead. Okay. So here again, what would be, we need to do a poll? We'll go ahead. So again, what is the role of the type of cannulation here? Whether it's going to be percutaneous, cut down, it's all institutional, but percutaneous ECMO in an advanced setup is very easy to set up, and it is recommended. So how, again the same thing, how are we going to assess the cannula size? We'll not go into the details. We'll go ahead with the other scenarios. So this is just to show how is the distal perfusion going to be, how is the return cannula going to be, and how the distal perfusion is secured. Go ahead. So this is the cannulas which was placed on that patient. He had a drainage cannula of 23 French, return cannula 19 French, and a distal cannula 7 French. So what are the scenarios we encounter in a Vva Ecmo? Having established a Vva Ecmo, what are the scenarios we are going to encounter? So this is the patient already on Vva Ecmo. You are seeing that there is no pulse pressure. His mean pressures are 65, good saturation and settled pulse rate. Go ahead. What is it? So what will you check here? So we have put this patient on a peripheral Vva Ecmo. So what are the problems we encounter putting this patient on a peripheral Vva Ecmo? So that is what we are going to deal with here. See, Vva Ecmo per se, the return cannula in the aorta imposes a huge afterload to the patient. Already the patient's LV is failing, and your cannula, return cannula is sitting right there in the aorta, and it is going to cause a huge afterload to this patient, and the LV, already failing LV, is going to strain more. So this is the most common problem which we encounter in a peripheral Vva Ecmo in a sick and failing LV. So what is this? Can you play that video? So if you see this video, this is a transesophageal echo 4-chamber view. The LV is distended and LV is curled. The blood in the left ventricle is curling and there is huge stasis. So what happens in this kind of a scenario is, the patient, you are already established an ECMO, he will have a fulminant pulmonary edema because the LV pressure, LV stasis is there and there is back pressure into the lungs, and he will have pulmonary edema. So this is a common scenario. How are we going to manage this? What are the steps? Anyone? How can we manage this? Very commonly encountered, and what we can do practically. Anyone? Yes. So I think first thing is, instead of thinking of other things, is first thing is reduce the afterload. If possible, reduce the afterload to the LV. So what we can do is, if the flow is like 4 liters, it may not be possible. He might require that amount of flow. We can come down on the flows and see. Okay, that is first thing. Second thing is, how we can help to eject the LV in some way. Help LV by giving some inotropes, by starting some inodilators. So these are all the rooms before we go to the final common surgical pathway. So that is first thing. Second thing is, use some inotropes, inodilators, give good diuresis to the patient. So basic steps we can do. Then also it is described, like how we showed in one of our patients, ECMO and IABP is described. So the IABP helps to unload the LV to some extent, and it helps to prevent distension. Now, of late, what is the newer Cath lab minimally invasive techniques is putting an impella on these patients. So impella also acts something like an IABP, and it also helps to reduce the afterload of the patient. Finally, if nothing is going to happen, we are not going to achieve all this, and the patient is having fulminant pulmonary edema, we are not able to manage, immediate bedside, this one will be putting an LV vent. So LV vent can be instituted in the bedside. What we usually do is surgically we can do a thoracotomy, put a cannula in the LV, left ventricular apex, and connect it to the drainage site. So I hope that video is there, LV vent video. It's not playing. It's okay. So I'll show you sometime. So what we do is put a LV vent and connect it to the drainage. So what happens is the stasis in the LV is taken care of by the draining into the drainage site. So you put a bifurcation Y. So there will be a femoral venous drainage and there will be a femoral left ventricular apex drainage. That will be a bright blood, this will be a dark blood. So that solves the problem. But having said that, what determines this decompression will be the size of the cannula again. You are going to put a bigger size cannula, LV is going to collapse and it is going to disturb the interventricular geometry, again RV is going to distend, it is going to be a vicious cycle. So we need to check again echo guided, we need to check whether optimal LV distension is there. We have adjustable clamps for that. So what we can do is we can put the clamp and based on the echo, how much LV you need to decompress, we can do with the clamps. So that is one of the practical way of managing. Yeah. So that just go to the previous. So this is an echo which shows for the same patient, if you can see there is an LV vent in the ventricle. So that is how it looks like. Yeah. So the next again common scenario is again on Vva Ecmo. Nurses.
Okay, one of your nurse who is handling the patient tells you that there is a drop in the saturation in this patient. So what are the things that are possible? Please go ahead. No, otherwise just show that slide only, Sindhu. Yeah. So you need to troubleshoot it. First and foremost thing is how is the pulsatile flow? If it is non-pulsatile, it may happen that what you are sensing may not be the right thing. Quite happens in Vva Ecmo where your pulse pressure is very low. Then you just check your artery line whether the blood is dark or not, whether you're on good flows or not. After doing all this, what you find out in this case is that the probe is placed on the right hand, which is a very common practice in the ICU. And as discussed before, you are on a peripheral Vva Ecmo. So it happens that it has been picked up that the saturation on the upper limb is low. So that was the whole point of stressing by multiple speakers right from yesterday, that we should have a preferably radial arterial line. If we have one, that will tell us whether what we are seeing is right or wrong. It may be right, it may be wrong. Or in that case, if you have only femoral artery, it may falsely show always a very good number. Even if you are on very low flows, you'll see that femoral artery PO2 will be 300, 400 like that. Can we proceed further? So in this case, we had a right radial ABG. That is what the ABG showed, a saturation of 65% with a low PO2. So what are we dealing essentially here? Anyone, what are we dealing? Like displayed there, that's what we are dealing. The north-south syndrome or the Harlequin syndrome, what they say. It is common to see that because it happens that when the trouble, initial phase of trouble, like Veena said, you have LV distension, all these things, lungs will become wet. Then slowly the heart starts recovering, but it may happen that your lung has not yet recovered. So in that case, you see this, your lungs are not good, but your heart is still ejecting a bit. It is very important because this is saturation which is going to the coronaries and cerebral. So for that reason, it is very important. If your patient is awake, whether awake on ventilator or totally awake, you see them first manifesting with a lot of confusion, restlessness, irritation. That's how you know that there may be an issue. That's where you start diagnosing or looking for this particular problem. So how do we approach this? What are the ways to handle this? First, can anyone say quickly? You work on all possible ways. First, through your lung, you will work. You increase your FiO2 or PEEP. You try to make your lungs better. What is the reason? Pulmonary edema, infection. You go and handle that accordingly. If that is not able to settle it down, try to increase the settings. No, then increase the ECMO flows so that more flow is there, and even your radial artery or the coronary and cerebral circulations get oxygenated blood. If nothing works, that's the final resort. What is written there? The veno arterial venous ECMO. You take a separate limb. You make sure you put a small size cannula, not a large one, through your jugular. Because otherwise, if you give 5 liters, 3 liters will go through the jugular. That will again distend your ventricle and make things bad. You put a small size cannula and put a occluder so that you regulate the flows and you just give what is necessary to have a target saturation of 90%. That will be the target in these cases. Next one. So that's the configuration of a VAV ECMO. Go ahead, next one. So this is finally the scenario where you commonly see where you will be able to wean the patient. Okay, you serially monitor echo as discussed before by this thing. So once you start an improvement in contractility, it may not become 60%. Once you see anything more than 25-30, you're good enough to consider start inotropes and then if possible float a PA catheter and get the numbers out of it and then start making your weaning trials. What is important here is target a higher anticoagulation at that point. Unlike VV, you don't have the option of coming down on your sweep gas flow. You can't come down beyond one level because it will be a shunt with causing a desaturation and secondary side effects. So here you have to come down on your ECMO flows. When you are coming down, it is very important that you maintain an adequate anticoagulation, and if you have a distal limb perfusion, make sure that the limb is not ischemic. These are the two very important things. Okay, and finally, if you feel the patient is tolerating, here unlike VV where you can put off sweep gas flow and wait for 24, 48 hours, or if you need more than that, here that option won't be there. You come down to low flows, you see how the patient is behaving, get the parameters, keep minimal possible anotropes so that there is still some room to increase in case it happens, it deteriorates after you take it out, then you plan a decannulation. A VV, you take it out, take a purse string compress, but VA arterial part has to be repaired always. Even if you do a percutaneous, you have to be repaired always. Okay. Next, that's it. So that's it, both VA and VV scenarios. Anyone has any questions, we can discuss. You want to add anything? Thank you, everyone. Thank you for being patiently here till the end of the sessions. I appreciate all of it. Then thank you, Macway team, for helping us for this simulation. Thank you.